foodborne disease surveillance. I welcome you all to this exciting series of talks that we have on the agenda today. And also, I would like to especially thank the CDC India office along with their colleagues in the US for facilitating this webinar. We are really thankful to all the colleagues from CDC India and US for being on board, and also would like to thank each of the speakers who has agreed today to give their very, very valuable insights to us. So with this, I would start with the first speaker. And our first speaker is Dr. Carmen Savelli. He has been in the World Health Organization since 2010 and is currently serving as a technical specialist in the Department of Nutrition and Food Safety, focused on global foodborne disease surveillance and food safety monitoring. Prior to joining WHO, Dr. Carmen worked at the Public Health Agency of Canada within the Center for Foodborne Environmental and Zoonotic Infectious Diseases, investigating national outbreaks of foodborne illness. His academic background is in biomedical science, BSc, and MPH, PhD in public health, with a focus on matters related to international collaboration and response to foodborne disease outbreaks and food safety emergencies. So, Dr. Carmen, I welcome you to this webinar, and I would really request you to give your insights on this often forgotten but very, very important topic of foodborne infections, which is also a very integral part of the One Health approach, which the countries are embarking on. So welcome, and over to you.
Great. Thank you. Thank you so much for that warm welcome. And let me add my greetings to all the participants today. Can you just verify you can see my slides okay in the full screen mode?
Yes, absolutely.
Okay, wonderful. So thank you very much. And I'm really grateful to be here and pleased to be able to provide you with an overview of the WHO Alliance for Food Safety and discuss a little bit about our global efforts to improve foodborne disease surveillance from the perspective of WHO. So I'll talk a little bit about foodborne disease surveillance and how it is integrated into the WHO global strategy for food safety, and then highlight a couple of tools that we have, the WHO manuals for strengthening surveillance and response to foodborne diseases, and then spend some time talking about the WHO Alliance for Food Safety and a short case study. But first, of course, it's important to note that access to sufficient amounts of safe and nutritious food really is key to sustaining life and promoting good health. But of course, we know that unsafe food containing harmful bacteria and viruses, parasites, or other chemical substances actually causes more than 200 different diseases, ranging from diarrhea all the way to cancer. And unfortunately, we also know that there's an estimated 600 million cases, or almost 1 in 10 people in the world every year, are falling ill after eating contaminated food. And actually, around 420,000 of those are estimated to die each year. So for all those reasons, it's really important that establishing and strengthening national foodborne disease surveillance systems globally is so critical for understanding and then ultimately reducing the burden of foodborne diseases, and that's really in line with WHO's global strategy for food safety. So if you're not familiar with it, WHO's global strategy was adopted in 2022 at the World Health Assembly and will run until 2030, and it really strives to bring together the global community towards stronger food safety systems through global cooperation. And if you look a little bit more closely at the strategy, including the different priorities and objectives, one of those focuses very closely on strengthening food monitoring and surveillance programs. And it highlights how important that is as a necessary component of a national food control program. And so surveillance of foodborne diseases in the population really is key and essential for monitoring the safety of the food supply. And through doing that, identifying outbreaks, estimating the burden of illness at the national level, as well as monitoring epidemiologic trends and various modes of transmission are all key responses. Now, WHO has issued various guidance documents and technical tools to support member states to really try and strengthen their capacity in foodborne disease surveillance. But unfortunately, we still know that capacities for foodborne disease surveillance globally are limited. So if you look even a little bit closer into the strategy, we know that one of the key indicators for monitoring implementation of the strategy is about surveillance. And if you look at what the indicator baseline was in 2022, it's measured here 1.5 out of 5. So what does that mean? It means that, in fact, many countries have either no capacity or a very limited capacity for their foodborne disease surveillance and food contamination monitoring efforts. And what we'd like to do as a global community is move towards a situation where countries, on average, have a capacity of 3.5 out of 5 by the time we get to the end of the implementation of the global strategy in 2030. So that would mean countries are sitting around a place where they have developed and demonstrated capacities for incident and event-based systems that include laboratory analysis to identify the etiology of foodborne diseases when they're detected, as well as investigate outbreaks when they occur and conduct rapid risk assessments at the national and subnational levels. And then, of course, beyond 2030, we'd like to see all countries with a sustainable capacity that's looking at data from across the entire food chain. Now, this work hasn't started with the global strategy. There's a long history at WHO of working on efforts to improve foodborne disease surveillance. If you look back to 2000, there were efforts to improve global salmonella surveillance through a network called the Global SAMSURV. That evolved over time into something called the Global Foodborne Infections Network, or GFN. And that was really a capacity building program taking advantage of different resources around the world and technical institutions that could help with capacity building on both the epidemiologic and laboratory side to improve the detection of foodborne infections all over the world. Now, with the introduction of the global strategy in 2022, GFN actually evolved and morphed into the WHO Alliance for Food Safety. And so through this process, over the years, there's been the development of different tools that WHO has to help and try to improve global capacities for foodborne disease surveillance. And one of those important tools is the set of manuals that you can see here on the screen. And this set explains how countries can strengthen their current foodborne disease surveillance and response systems and actually try and integrate them into existing surveillance and response systems, which are requirements under the international health regulations. And so I encourage you to take a look when you have some time into these 5 different modules, which provide comprehensive guidance that would be required within your countries to conduct a self-assessment and see what's going on in terms of capacities that exist or might be requiring some improvement, identify the gaps, and then work with various stakeholders who are involved in surveillance in the country and manage implementation as you work in a stepwise way to build surveillance capacities. So what would that look like in practice? Well, for the countries that I mentioned that are either with no capacities or very limited capacities, they would start in stage 1. And so they would work towards trying to implement a system using event and indicator-based surveillance to detect foodborne events. So to detect outbreaks and implement a response effort and public health interventions to specific events. And once the capacities are developed in stage 1, there's guidance that takes those countries to stage 2, where they focus on strengthening indicator-based surveillance. And an important component here is on laboratory-based notifiable disease surveillance, and doing so in a multi-sectoral way, as well as incorporating data from ad hoc studies that could add additional information to the gaps that might exist in our understanding about the burden of illness and about source attribution, for example, allowing for ad hoc public health interventions to be implemented across the food chain in a reactive way, and then graduating all the way to stage 3, where the focus is on integrating surveillance data to better understand risks in the food chain. And so that really means looking at data from all the points along the food chain and being able to implement regular public health interventions in a more proactive way. So that's kind of the framework that WHO uses, and hope that towards 2030 and beyond, we can help countries get to a place where they have an integrated food chain surveillance system. And that takes me to the new WHO Alliance for Food Safety, which will have an important role to play in this regard. So the alliance itself was launched in May 2024 during an inception meeting at WHO headquarters. And what it is a global network of our WHO collaborating centers and other partners that are helping to work towards implementing the global strategy. And so they really want to focus on strengthening national food safety systems and reduce the incidence of foodborne diseases worldwide, and do that through enhanced multi-sectoral collaboration and improved foodborne disease surveillance and contamination. That's the initial focus for the first 2 years. And so we'd like to drive a global initiative through the alliance that really raises the awareness of the importance of food safety. As our speaker at the start introduced, often it's overlooked. And so it's so important that we shine a light on this important topic. And the alliance is hoping to do that, and also to mobilize resources to support food safety programs and really try and foster partnerships between the different collaborating centers that are working in this area, together with governments, international organizations, and other partners. So there's 5 objectives for the alliance. And the first one is perhaps the broadest, which is to enable an environment for multi-sectoral coordination and collaboration to help implement the strategy with this initial focus on foodborne disease surveillance and food contamination monitoring. And it'll try to do that through advocacy for legislative and policy frameworks to be in place related to food safety more broadly, and then an integration of foodborne disease surveillance and contamination, taking a One Health approach. And of course, that involves a multi-sectoral collaborative approach, as well as efforts to monitor the various activities linked to the global strategy. The second objective of the Alliance is to advocate for and promote legal frameworks with provisions for surveillance of foodborne diseases and food contamination. We know that often foodborne diseases are not included in notifiable disease surveillance systems. And so we really want to see the Alliance helping to advocate for these legal frameworks to be in place as essential components of national food control programs, and that there's advocacy to various government entities for the recognition and real importance of this area, so that resources can be allocated appropriately to this area. The third objective is to build capacity in public health, animal health, and food safety laboratories. And so that means helping WHO support member states to build their capacities, so resources, technical capacities, and infrastructure, so they can conduct the necessary analyses and report at national and international level. And we know that that can cost resources, and so we want to help mobilize those resources so that member states can build their capacities, put in place the infrastructure and sustainable systems and networks within the countries to improve foodborne disease surveillance. The fourth objective is to generate and share quality data and information. And so we know that there's a lot of gaps that exist. As you saw with the indicator, most countries have very limited or no capacity in this area. So generating useful data that can be used for evidence-based decision-making is a really important function for the Alliance. And then sharing that information with each other, with the global community, to inform and update the development of evidence-based food safety policies and risk assessment and response to outbreaks. And then finally, the last objective for the Alliance is to share best practices and lessons learned amongst members. And I think this is a really important one, because there's always so much we can learn from each other after there's been a big outbreak, or when various steps have been taken in one country to improve their surveillance system. Others can always learn from the challenges and how those have been overcome. And so we really want to see peer-to-peer learning and the sharing of diverse experiences and perspectives through participation in the Alliance activities. Now, in terms of the working methods, we've got a work plan that's been developed with Alliance members, and that's been validated by a steering committee. We've got a few different working groups that have been set up and are being led by our members. And then the Secretariat will be taking forward the cross-cutting activities together with our steering committee. So right now, we've just launched the four working groups that exist. One of them is focused on foodborne disease surveillance integration, another one on food safety policy and coordination, another one on lab capacity building, and a final one on data and awareness. And so we're really excited to see those get up and running and work towards implementing the work plan of the Alliance, carrying on from the historical legacy of those other previous networks like the Global Foodborne Infections Network to implement the global strategy. So in the last couple of slides here, I just wanted to focus on a case study, which here talks about the largest ever outbreak of listeriosis that was reported in South Africa back in 2017 and 2018. And this was really characterized by a progressive increase in cases of the disease from January 2017 all the way until July 2018. So quite a significant event for the country, which resulted in more than 1,000 cases of lab-confirmed listeriosis, and unfortunately, more than 200 deaths. And it was linked to this particular type of ready-to-eat meat product, which had actually been produced in South Africa and exported to a number of other countries. Now, while of course these instances when foodborne disease outbreaks strike, they're always tragic events, but hopefully when they do happen, we can learn something from them. And that was certainly the case in this instance. There were a lot of lessons learned and positive changes to foodborne disease surveillance and response system in the food safety system more broadly in South Africa. So first, the event resulted in improved notifiable disease surveillance. So listeriosis was added to the list of notifiable diseases in the middle of that outbreak. They also worked towards enhanced laboratory capacity, so improving lab testing capabilities, including using new technologies like whole genome sequencing for more accurate outbreak detection and tracing, as well as strengthen food safety regulations. And so what happened here was there were, highlighting some of the gaps in their food safety regulations, particularly around processed and ready-to-eat foods, as was this particular ready-to-eat meat product. And it led to the stricter enforcement of hygiene and food safety standards in food production, processing, and retail sectors. It also spurred these campaigns to educate food producers, retailers, and consumers about listeria risks and food safety practices, and also led to training for health inspectors, lab technicians, and food safety officers so that they could improve their skills and knowledge in outbreak investigation and foodborne disease prevention. And that included in collaboration with WHO through what at that time was the Global Foodborne Infections Network, or GFN. And so I think that it's so important to highlight that in addition, it underscored the importance of taking a coordinated approach and response to the outbreak and collaborating between stakeholders. So while there were, we never want to see outbreaks like this happen, but if they do, it's really good if the global community can sometimes learn from them and apply those lessons learned to their own scenario so that the same issues can be prevented in the future. So I'm here arriving at my conclusion. And so what I want to emphasize is that around the world, national food monitoring and surveillance systems really do need to be improved through prioritization, better coordination, collaboration, and integration. And doing so is going to help contribute to a safer global food supply, which we know is so interconnected these days. And we can then work together towards reducing the global burden of foodborne diseases and try to meet those targets that are outlined in the global strategy for food safety. And we're excited that we now have the WHO Alliance for Food Safety, which is established to help implement the global strategy with this initial focus on surveillance and monitoring. And we also have our tools that are available, the WHO manuals, which provide this structured approach to achieving more strengthened systems. And so from our perspective at the WHO, we're so pleased that we're able to work with our partners and advocate for this work and ensure that it gets more attention, because we know that unsafe food still presents a significant health burden globally. So thank you very much. I'll stop here.
Thank you, Dr. Carmen, for that excellent talk. and you gave a very beautiful overview of what are the guidance documents available within WHO and how they can be used by countries to set up an agenda for surveillance and detection of foodborne infections. And you also gave some very pertinent examples, like the listeriosis outbreak of South Africa and how it led to changes in policy and bringing attention towards looking at food safety as an integral component of public health. So thank you very much for that excellent talk. And maintaining the momentum that has been set by Dr. Carmen, we would now move to our second speaker, and we would take all the questions in the end. You can leave the questions in the chat box, requested all of you. Dr. Heather Carleton. Dr. Heather is MPH PhD and is the chief of Enteric Disease Laboratory branch in the Division of Foodborne, Waterborne, and Environmental Diseases at the National Center for Emerging and Zoonotic Infectious Diseases, Centers for Disease Control and Prevention, USA. Dr. Carleton joined CDC in 2012 as a microbiologist and led the development of whole genome sequence-based analysis tools for the transition of the foodborne molecular surveillance network, PulseNet, from pulse field gel electrophoresis to whole genome sequence-based approach. She serves as a chair of PulseNet US and co-chair of PulseNet International Steering Committees. Dr. Carleton leads activities in prevention of enteric diseases, bioinformatics, metagenomics, and next generation sequencing in EDLB. So a warm welcome, Dr. Carleton, and with your vast experience and your knowledge, we look forward to a lot of valuable input sharing from you. So over to you.
Great. Thank you so much for having me today. I'm looking forward to talking with you all about the work we do as part of PulseNet International. All right. And do you see my slides okay?
Yeah, but they are still not in slide show mode. Now they are perfect.
Okay, great. So first I'm going to talk a little bit about how our domestic network works, PulseNet USA. We're an active pathogen genomic surveillance network for enteric diseases in the United States. We've been around since 1996. And within the US, all 50 states do whole genome sequencing, and that data is submitted to a central database at the CDC in Atlanta, Georgia. And then we look at the sequence data that's submitted from our public health labs to our centralized database to identify multi-state outbreaks, which are identified with illnesses that have the same molecular fingerprints. So we find close genetic matches. And when we find these close genetic matches, our PulseNet data analysts identify approximately 1,000 potential outbreaks every year. And then we work with our epidemiologists at CDC, FDA, and USDA to identify the potential outbreak sources. So within PulseNet, we detect foodborne disease case clusters that may be widespread outbreaks of multi-state. We are a real-time molecular surveillance system of the most important bacterial foodborne pathogens in the US. And many of these are shared with PulseNet International too. So E. coli, Salmonella, Shigella, Listeria, Campylobacter vibrio, and Chronobacter. We work closely with foodborne epidemiologists to investigate potential outbreaks, and we act as a rapid and effective means of communication between public health laboratories. And this is true both domestically in the US and also internationally. And then a large amount of the work we do is provide training and capacity building for whole genome sequencing. And we work with partners like WHO and the Alliance to share experience, training, and really build capacity for foodborne disease surveillance. We also collaborate with other laboratories, so food regulatory, agriculture, academic, and public health labs, or the equivalent of ministries of health. And transitioning to PulseNet International, for PulseNet International, our focus is also foodborne disease surveillance and doing molecular subtyping. We were established in the early 2000s, and our vision is worldwide regional and national laboratory networks utilizing standardized genotyping methods and sharing information in real time to enhance surveillance and provide early warning of food and waterborne disease outbreaks, emerging pathogens, and acts of bioterrorism. Within PulseNet International, we're broken into 8 regions listed here. India is part of our PulseNet Asia Pacific region and has been an active member for many years. And we work with over 80 countries from across the world. And our focus is on building that laboratory capacity. Through laboratory capacity, being able to perform antimicrobial resistance surveillance, providing quality assurance for our laboratory techniques, and also communicating between our laboratories and epidemiologists and really helping interpret the data we generate for public health action. We are, for PulseNet International structure, we are administered by a steering committee that meets quarterly. So currently I'm the co-chair of the steering committee with PulseNet Canada, and we include representatives from each region. So each region I listed has a regional coordinator that's responsible for coordinating with the countries that are part of PulseNet International within their region and providing a point of communication back and forth with the steering committee. Our key priorities are technical assistance, sharing of resources, training, communication, and data exchange. And regional coordinators are really the first point of contact for new laboratories joining the network. Primarily, the labs that join are part of the human health sector, so ministries of health or ministries of public health laboratories, and can invite food sector collaborators in country to join, so FDA or USDA equivalents in countries. And they may choose to develop a memorandum of understanding and or terms of reference to define how data is shared or things are communicated within their regional network. And really by joining the PulseNet International and regional groups, you can leverage key partnerships and pursue funding opportunities to implement activities at a regional level. And as I mentioned before, India has been an active member in PulseNet Asia Pacific. So this is a picture from when India graciously hosted a PulseNet Asia Pacific meeting in 2008 in Calcutta, India. And in this picture, we have many of our PulseNet Asia Pacific regional members and our PulseNet Asia Pacific regional coordinator at the time, which is Kaiman Kim, who has since stepped down in that role. And now our regional coordinators for PulseNet Asia Pacific are Ben Howden and Tuyet Hong from the Center for Pathogen Genomics at University of Melbourne in Australia. And recently for our PulseNet International work, we've been expanding our work to have genomic and microbial resistance surveillance of enteric pathogens. We joined our US CDC's Global Antimicrobial Resistance Laboratory and Response Network to integrate PulseNet sequencing methods for antimicrobial resistance detection in enteric bacteria. As part of this work, we've developed standardized workflows in a bioinformatics cloud-based platform called Terra for bioinformatics analyses. And then within PulseNet International, we provide training in these methods in bioinformatics as well as the wet lab methods. And we've had in PulseNet Asia Pacific specifically, we've had projects focused on antimicrobial resistance. We've been able to procure reagents through a partner, Association of Public Health Labs. And each site that is a participant in our feasibility study was given reagents to sequence at least 100 isolates. So this is just a quick overview of this feasibility study. We sent out a request for proposals to our PulseNet Asia Pacific members in 2022 and 2023, our first cohort consisted of Thailand, Malaysia, Taiwan, Philippines, and New Zealand. And they did a variety of projects across different enteric pathogens, focusing on genomic characterization of pathogens that were most important from their country perspective. And then we began a second cohort in the region that includes Bangladesh, Sri Lanka, Japan, and Vietnam. And really the keys to success for this engagement have included early engagement through communities of practice, webinars, and virtual trainings. So we have monthly calls still with our feasibility study members to talk about different topics in AR and enteric disease surveillance, analysis methods, address any questions, and plan for future studies and share data within the network. We were also able to work with industry partners to identify procurement and cost challenges, and that has been really key to facilitating the success for our PulseNet Asia Pacific feasibility study is helping the companies and providers of reagents understand the challenges that were occurring in public health, bringing them together to discuss it and resolve the challenges. And then the whole genome sequence studies we performed provided a way for members in national labs in the different countries we work with to really strengthen their ability to do sequencing analysis and develop manuscripts and abstracts regarding their work. And through this initial work we did with APHL and with partners in industry, in this case Illumina, we were able to work with Illumina to develop an equitable pricing program. This was launched in 2023 and really focuses on global health equitable pricing and set pricing for Illumina reagents and equipment. To be eligible for it, implementing partners are eligible, so like our partnership with APHL, UN organizations on behalf of public health laboratories, and LMICs for genomic public health surveillance are also eligible. And listed here is a few contacts at Illumina if there's questions about PulseNet equitable pricing. Another part of our program is a quality assurance program. So for PulseNet, we provide a certification, which is a wet lab process to show that within the wet lab, the data can be generated at an adequate quality. We also have certification program. And we also have that certification by individual. So each individual performing the laboratory method is certified. We have an annual proficiency testing program that's coordinated through PulseNet USA, and now we are working with PulseNet International Labs this year. And PT can be submitted by laboratories, and we do about 5 different enteric bacterial samples. And then for data analysis, we're also developing a data analysis challenge set for showing that bioinformatics can be performed correctly for different sequence data generated from enteric bacteria. So far within PulseNet Asia Pacific, we've trained 26 scientists in 2 cohorts for Illumina. And then we've also piloted a Oxford Nanopore training with 29 scientists for 14 countries. Within the Southeast Asia region, our Illumina training has focused on Bangladesh, Sri Lanka, Thailand, Timor-Leste, Malaysia, Philippines, and Vietnam for the ONT training. We also provide monthly office hours for the second cohort I mentioned. We're in the process of doing certification, and we have multiple sequencing projects underway. Some remaining gaps are still challenges with data sharing. really doing that training on how to use that data that's generated by sequencing for action, so genomic epidemiology, and then working together to identify trends in antimicrobial resistance within the Asia Pacific region. So now I'm going to shift gears a bit and talk about how implementing sequencing can really change the dynamics and trajectory of an outbreak. And this is an example we've used with some of our other PulseNet international regions that really highlights the impact implementing whole genome sequencing can make. So I'm going to be talking about a Salmonella typhimurium outbreak, or salmonella outbreaks linked with peanut butter products. The first outbreak that I'll be talking about occurred in 2008, before we had implemented whole genome sequencing, and we were using the previous technology, pulse field gel electrophoresis. We detected 714 cases in 47 states. There was 166 hospitalizations due to this outbreak and 9 deaths. And the peanut butter was found to be a statistically significant exposure. There was a long period of onset dates, and really detecting this outbreak and identifying the source, finding subclusters or groups of cases that then we could follow up on was really critical. And then in 2022, we had another salmonella outbreak linked to peanut butter. This is when we had implemented whole genome sequencing, and you can see the trajectory and the size of the outbreak is quite different. At this point, from detection to close of outbreak, we had 21 cases. It was detected in 17 states, and there were 4 hospitalizations and 0 deaths. The onset range was much shorter, so a few months rather than almost a year. And we were able to quickly identify peanut butter as a statistically significant exposure. And with whole genome sequencing results, we were able to link cases with a lot of confidence because there were 0 to 4 SNPs between the cases that we identified. And then this is just showing the trajectory of the outbreak. So whole genome sequencing helped accelerate our 2022 outbreak response, with fewer illnesses triggering the outbreak detection. So within a few months, or a month and a half, we detected 6 cases and were able to identify it as a potential outbreak. In the previous outbreak that was detected by PFGE, it occurred over 2.5 months, and we had 12 cases until we detected the outbreak. And then for the sequencing example, from suspicion of an outbreak to identifying the source was 2 days. For our prior outbreak during PFGE, it took 55 days to suspect peanut butter, in which you can imagine if you have a longer time till you detect the outbreak source, there are more people getting exposed and more people getting ill. So the first recall was much faster in the case of whole genome sequencing versus PFGE. And really, this shows the impact of PulseNet and the impact of using molecular surveillance. And in a previous economic study we did just by implementing a molecular surveillance network like PulseNet, we were able to show that we save at least $500 million each year in medical costs and lost productivity. And we're a good return on investment. So for every $1 spent, we have $70 saved. And then we prevent approximately 270,000 illnesses. So implementing something like genomic surveillance can really have an impact on decreasing the number of foodborne illnesses you see, and an impact on decreasing the cost of those illnesses to your economy. So within India, there are several potential areas of collaboration, including training, sharing our experiences with network building, and then potential next steps for working together is also reaching out to our PulseNet Asia Pacific coordinators at the University of Melbourne at the Center for Pathogen Genomics. This includes Hissini and Tia, and their emails are listed here. And then within the United States, you are always welcome to reach out to us at edlbglobal@cdc.gov. We do have a NGS implementation guide that goes through the needs for a laboratory for setting up sequencing. We also have a APHL PulseNet International website, and all of our SOPs are listed there, so I recommend you taking a look. And then on the learning portal, we provide trainings, and we have some recent trainings on working with NCBI and looking at sequence data on the pathogen detection page. So thank you for the opportunity to present today, and I look forward to answering any questions you may have and hopefully working with you in the future. Thanks.
Thank you very much, Dr. Carlton, for that extremely useful talk, I would say. And you very clearly brought out that how the PulseNet was scaled up not only in US, but other parts of the world, and very appropriately bringing out the role of genomic sequencing and how it could shorten the time when you can detect and control the outbreak. I think these newer tools are so useful in quick detection and prevention, and also preventing the spread of these foodborne infections. So thank you very much for your useful insights. And we would definitely want to collaborate with you in future, and we can discuss this separately. So with this extremely useful talk given by Dr. Carlton, we would now move to the next speaker, which is Dr. Idaya Karuna Sagar. Welcome, sir. Dr. Karuna Sagar, all of us, at least in India, know him very well, and I know he's an internationally acclaimed scientist as well. He has obtained his master's and PhD degree in microbiology from Mysore University, India, and carried out postdoctoral research at University of Maryland, USA, University of Sendai, Japan, Natural Resources Institute, UK, and University of Würzburg, Germany. He played a key role in the development of international food standards at Codex Alimentarius Commission. He played a pivotal role in the development of WHO 5 Keys for Safer Aquaculture Products. In 2021, he was appointed as a member of WHO Advisory Group on critically important antimicrobials for human use, and he is a member of WHO International Team for source attribution of foodborne diseases, and also a member of WHO expert group on risk-benefit assessment for nutritional guideline development. He is currently advisor FAO, Reference Center for Antimicrobial Resistance and Aquaculture Biosecurity, NITE University, Mangalore. So over to you, sir. We look forward to your very valuable insights. Over to you, sir.
Yeah, thank you. Thank you very much for the kind introduction, and also for the opportunity to participate in this very important webinar. Am I audible and the screen visible?
Yes, sir.
Okay,
you're audible and screen is visible.
Okay. Thank you. Thank you very much. So I will try to give the FAO perspective on this foodborne disease surveillance. Yeah, so when we try to recall what are the objectives of a surveillance. So surveillance is defined as a systematic and ongoing collection, analysis and interpretation and dissemination of data for public health action. So the objective could be to estimate the burden of disease in order to determine the magnitude of the problem, or monitor trends and know whether the situation is improving or worsening, detect outbreaks and determine urgent action, and assess control programs to obtain information on their performance, and generate data to be used in risk analysis and ensure safety of food supplies. So for this, of course, FAO is working closely with WHO and the InfoSan International Food Safety Authorities Network. And this InfoSan advises the countries to have um, different focal points in all the related ministries in One Health context. For example, focal point in agriculture, veterinary, and also in health, and also trade, because a lot of food commodities are traded. So these focal points contact the secretariat, and two focal points are advised. One is a focal point for InfoSan for the other outbreaks, and for one for emergency contact points. So the terms are also indicated here. So these network actually helps dissemination of information globally, and for countries to learn from each other. So this is an important network in which FAO is working very closely with WHO. And then, of course, FAO is working also with WHO in terms of the SPS agreement and the Codex Alimentarius Commission, which is the international standard setting body. And as per this SPS TBT agreement, the member countries have the right to set standards based on appropriate level of protection, which could be in terms of number of outbreaks and how much of reduction that can be achieved and what needs to be done to achieve this. And Codex Alimentarius Commission is the food standard setting body, and the secretariat is based in FAO in Rome. So the standards and also the course of practices and guidelines are available from the website of Codex Alimentarius Commission. So here I would like to focus on one of these guidelines, which is on the management of biological foodborne outbreaks, which is adopted in 2022. And this gives information on how to manage outbreaks and how to investigate outbreaks. And in the annex, you can find this diagram which shows the interaction between the national network, local network, because in a big country like India, and where health could be a state subject, so you need local networks which interact with each other and then provide information to the national networks, and then finally to the international networks. So this is just to illustrate how this could work. And also, the competent authorities, the health authorities may decide regarding an incident, whether to call it an incident or an emergency or a crisis, depending on the number of cases, the geographical spread, the disease severity, the population affected, and what is the organism that is involved, and what is the source of contamination, distribution pattern, and consumer perception about this disease. And also need to remove or reduce the risk to consumers through public health actions such as recalls or likely exposure and consumption patterns, whether or not outbreak is intentional, is it the case of bioterrorism or any food fraud, and whether a hazard is known or unknown, or capacity of the country to deal with these and react quickly to minimize the impact. So this guideline talks about the preparedness system which the countries need to adopt. So this preparedness system involves creation of an official network between human health sector, food and veterinary school sectors at local and national levels, and international alert, that is the contact point like for InfoSan, and then surveillance and monitoring system and their use in foodborne outbreak situations, and also analytical methods. The previous speaker spoke about the whole genome sequencing. So you need to use various methods like maybe the PCR or typing methods, or multi-locus typing, or whole genome sequencing, single nucleotide polymorphism. So the capacity to do these need to be built up, and also rapid risk assessment and risk communication strategy. So under management, what are the main steps to investigate an outbreak and try to see how to manage this? So this involves identifying and investigating a foodborne outbreak, human health, and also involve food, and substantiate hypothesis or handling of a foodborne outbreak, food safety from primary production to consumption, combining epidemiological and laboratory data, rapid risk assessment and outbreak analysis during a foodborne outbreak, risk communication, documentation of the outbreak and lessons learned, and post-outbreak surveillance. So this is the guideline also provides a template for the data, how to collect all this information. So, for example, with regard to outbreak information, so what descriptive epidemiology can be, how it can be performed, like case definition, number of confirmed cases, going on to have an epi curve, and then analytical information regarding the human case of what is the agent involved, and overview of the human cases, and outbreak background information regarding the outbreak, how did it initially start, and what is the food, and where did it originate. So this kind of information needs to be collected. So this template, I think, would be very useful for countries to investigate outbreak. And in terms of illness background information, did it occur before? So has it been associated with this food? So what is the historical data say? And investigation of human cases. So this may include hypothesis generating interviews, food exposures that appear higher than expected based on available surveys, whether there are subclusters, case control, and cohort investigations. So this kind of data will help understanding the situation with respect to human health. And then investigations regarding food. For example, what is the food that has been implicated, and details regarding the code and how it has been stored, and what are the instructions provided on the label, and what are the analytical methods used, outcome of the laboratory analysis, and information on the tracing of the affected food ingredients. It could because a hazard could come from an ingredient, and tracing it back to the ingredients or source, and tracing it forward in terms of distribution of the product. And this is to be repeated for each of the affected establishment along the food chain. Then also identify data gaps to see what more information needs to be collected. Are there any identified common suppliers of the affected food? Then assessing the distribution of the suspected food, and description of the product conditions in affected establishments, information on the consumer behavior, eating habits. So this kind of information needs to be collected, and background information concerning the strain in food, the pathogen involved. So when more studies are done, like whole genome sequencing or typing, what is the relation between the organism that is present in food and that has been implicated in the human cases. So linking epidemiological data with the laboratory data coming from the human cases. So this could be the typing data or whole genome sequence information. So this would help to understand the link between the food and the outbreak. And we need to also identify data available or not available. So what are the uncertainties in the available data? So that would affect the conclusions. So if any data is not available, there should be clearly stated and how this could be, these data gaps can be filled, and what are the communication strategies. So clear information, how the stakeholders can be informed about this, and what more needs to be done to minimize the impact of the outbreak. And I think previous speakers also talked about rapid risk assessment that needs to be done. So in this guideline, there is also this template on how to perform this rapid risk assessment. What are the possible questions? Now, for example, questions related to the suspected food item. So is it possible that it has been produced under specific conditions? So we try to identify how the food has been produced from primary production to processing, and finally at the retail stage, and what is the outbreak agent that has been detected, and where was it detected, so to identify the source of contamination. And then possible question related to the agent. So what do we know about the organism? Where does it occur? How does it enter the food chain? So these kind of questions will help to perform a rapid risk assessment to understand the implication of the suspected pathogen in the outbreak. And so we need to understand more about the organism, and how it occurs in whether it is present in the production facilities. So did it occur at the processing stage, and whether it is linked to foodborne outbreaks in the past. So this kind of information will help in performing rapid risk assessment, and also this possible question related to use of certain food items and consumer eating habits, particularly with organisms like Listeria. Suppose the incubation period is quite long, and then what is the product that has been consumed needs to be investigated. So when it comes to risk communication, so we need to communicate with the stakeholders regarding the information that has been collected and how this can be used to inform consumers regarding avoidance of product or recall of products. And then at the beginning of the outbreak, during the period when the information is being gathered, there may be confusion. And that's why this needs to be avoided. So the confusion has to be always there. So it may be necessary to conduct communication even if the source of an outbreak is still under investigation, it's still unknown, but it's important to communicate what is being done to the stakeholders. And then documentation and lessons learned would be important because from each outbreak, we learn lessons and then try to implement the lessons learned in the next outbreak. So this kind of information that needs to be continuously evaluated, what went wrong and how that can be improved. And then I would also like to mention, of course, when I talked about Codex standards, so how are the standards made? Because that would help us to know the scientific basis for these standards. So FAO and WHO are responsible for answering any risk assessment questions that come from Codex. And if it relates to a microbiological issue, for example, there's a joint expert group on microbiological risk assessment. For chemical and veterinary drug issues, there is JACFA. For pesticides, there is JMPR. So the risk assessments performed by these expert committees, which consist of scientists involved from different countries, they provide independent advice to FAO and WHO. So the reports of these risk assessments go back to the Codex Alimentarius Commission to make these standards, criteria, or residue limits. So this shows the scientific basis for the standards that are set by Codex with the involvement of FAO and WHO. So with respect to microbiological hazards, there is this document which will give information on how to perform this risk assessment. If a detailed risk assessment is to be performed to understand the involvement of different commodities in different types of outbreaks. So this is a very detailed document when risk assessment needs to be performed. So from the output of these different committees like JAMRA, JECFA, and JMPR, we have different Codex documents coming out. Now, for example, we may say there has to be 0 pathogens, but can we achieve this? And how to reduce the pathogens, for example, present in food, to what extent we can reduce. So these are there detailed in the codes of practice, like general principle of food hygiene, then code of hygienic practice specific for specific foods like eggs, meat, fish, fruits and vegetables, and then there are specific guidelines for control of pathogens. Now, for example, salmonella in poultry is a very big issue. How to control, how to minimize. So if we say salmonella has to be absent, what the producers can do or what the processors can do to achieve this. So this information is present in these codes of practice. Similarly, there are maximum residue limits for contaminants, veterinary drugs, and additives in food, and also for pesticides. So the Codex approach to microbiological food safety is mainly to implement good hygienic practice, good agriculture practice, good animal husbandry practice. So this has to be done at the primary production stage and at the processing stage, a system based on the hazard analysis, critical control point based food safety management. And sampling and testing is only for verification of these measures that have been implemented. So by adopting this practice, the major issues to be addressed are control of water quality, fecal contamination, food handler practices, and control of food contact surface cleaning, like Listeria could come from food contact surfaces. So most of the microbiological problems can be minimized by adopting these general principles of food hygiene as well as the code of practice, which are there for specific products. Now, as an example of Campylobacter and Salmonella, just to give some example, there are measures like hazard-based measures as well as GHP-based measures. So the hazard-based measure gives options to the countries, for example, using either chlorinated water following defeathering. So you can, and to what extent salmonella can be reduced by these kind of measures, that is also indicated in these codes. So the countries have an option to either use chlorinated water or a trisodium phosphate to reduce salmonella in poultry at this stage. And and this another measure, like for example, this also is regarding use of chlorinated water. So the code gives these kind of guidelines on how to produce safe food and how to minimize the presence of pathogens. So to summarize, what I would like to say is FAO is working with WHO to develop Codex standards, guidelines, and codes of practice. And these are based on risk assessments conducted by GEMBRA, JACFA, and JMPR. And Codex document provide guidance to improve food safety all along the food chain. Thank you very much.
Thank you, Dr. Karuna Sagar, for that extensive description of the various documents and risk assessment frameworks and determining the causality of foodborne outbreaks. I think that is a very, very useful resource that you just brought to everyone's attention. Thank you very much for that excellent piece of work and knowledge that you just shared with us. And again, maintaining the momentum of this webinar, we would now move to our next speaker, who is Dr. Himanshu Chauhan. And Dr. Himanshu Chauhan is a medical graduate from Maulana Azad Medical College at Delhi, and he's a postgraduate from Lady Hardinge Medical College, Delhi. He has also pursued advanced fellowships in public health from Maulana Azad and US CDC in Atlanta. He's a public health specialist with more than 20 years of experience in diverse capacities and situations, and public health management is his area of special interest. In his present role as the Joint Director of National Center for Disease Control at Delhi and head of the Integrated Disease Surveillance Program, IDSP, of Ministry of Health and Family Welfare, Dr. Chauhan has led the transition of IDSP to an electronic real-time platform, that is the IHIP. And just adding on, Dr. Himanshu is one of the coolest and one of the most cooperative public health experts and IDSP leads that has been there in existence. So we all hugely rely on him in times of outbreak and have a very, very high regard for him. So Dr. Himanshu, we look forward to your excellent talk and sharing your insights with us. Over to you.
Thank you very much, Dr. Nivedita, for that very kind introduction. And you have maintained the time so far very well. I would not like the time to be disturbed, the routine to be disturbed by me. So let me straight away get into my presentation. I'm just sharing my screen here. I hope this is now visible, and let me put it on the slideshow. Yeah, I hope the slide is visible.
Now we can see them. Yes, yes.
Thank you. So the talk that I have today, looking at IDSP data, is about surveillance of ADD and foodborne infections. What are the trends and gaps in outbreak data over the past 3 years? Just to give a background of IDSP very quickly, we all know that, in fact, if you look at the logo behind me, it says protecting the nation from epidemics. Some part of epidemics is visible. In fact, that actually starts with the outbreaks. So some major outbreaks in 1990s and incidentally happened to be diarrheal disease outbreaks, cholera in Delhi. They required that the country have a surveillance and response system which ultimately took the shape of IDSP, and it continues with domestic funds after the initial transition happened. And in 2021, the IDSP reporting, which was a weekly system, has now evolved into an electronic near real-time reporting system. The objectives of the program are to detect early warning signals of impending outbreaks. Public health actions need to be initiated once these early warning signals are detected. The This is through a trained cadre of responders at all levels, starting with district, state, and national levels, which are termed as the rapid response teams. Then this should lead to reduction of mortality and morbidity due to communicable disease outbreaks. This is just a glimpse of what are the diseases that IDSP is mandated with. So any disease communicable which has an outbreak potential, by default, the outbreaks of these diseases are mandated to in IDSP. So the idea of having this slide here is just to give an idea that what kind of data we are now looking at on IDSP, IHIP, almost real time. So this data is for the month of August, and we see that around 5 million syndromic surveillance cases, 4 million presumptive cases, which comes from the health facilities, and almost more than 3 million people who have been tested for various outbreak-prone disease conditions and their results. So this data, this kind of data is now available, voluminous and being case-based. It's very clean data by which the individual cases can be identified, located. Let's specifically look at the issue that we are dealing with today. So this data set here is the presumptive cases. That means this data comes from the health facilities, pertains to acute diarrheal diseases over the last 3 years. So we see that from 2022, 23, 24, every year. In fact, had we gone back in time, we would have seen that this is continuously increasing. So this is the reporting which is improving on IDSP IHIP platform, which is reflecting here. But clearly, there's also a pattern. If you look at it, the monsoon months national level data shows that there's definitely an uptick in the number of cases which are reported. While still we'll come on to as to what do these numbers mean from a public health point of view, and for a program which is mandated with detecting outbreaks and responding to them. We also look at cholera cases, since cholera is one of the most important public health conditions from an outbreak perspective. So over the last 3 years, we see that the number of confirmed cases of cholera, these are reported from laboratories which are equipped to confirm cholera. So once again, that pattern is reflected, and around July, August, we see that there's an uptick in the number of confirmed cases. But also interesting that throughout the year, there are isolated outbreaks. I'll refer to the outbreak slide in a moment, which happen from various parts of the country. We've kept salmonellosis here, although there are multiple causes. I would not want to go into those details, norovirus, adenovirus, rotavirus, or maybe even bacterial causes, which we don't do surveillance for, or we are not able to reach a diagnostic etiology in those terms. But salmonellosis, typhoid, enteric fever happens to be one of the conditions that is under the surveillance mandate specifically. And here also we see that the number of cases have been, reported number of cases have been increasing over the years. And somewhere after the monsoon, there appears to be a peak year after year. This is a dense slide here, lots of data on it. But what it essentially shows is if you look at the 3 years over the top, 2022, 23, and 24, we are looking at outbreaks. Those were the cases which were reported from the health facilities and the laboratories for typhoid and cholera, ADD from health facilities. These are the number of outbreaks which have been reported over these 3 years. And then we've also looked at outbreaks of cholera and typhoid. So outbreak by definition is clustering of cases and they are epidemiologically linked. So by that definition, if cholera and typhoid have been labeled as outbreaks by the district and state teams, then we have counted them as outbreaks. So the ADD outbreaks, the picture here is interesting. We see that in 2022, a total of 356, the grand total at the bottom of the slide, 356 outbreaks with 14,000 cases. And this number has gone up in 2024. This data is only till 25th August, but still by 25th August, the numbers were already 703 outbreaks of acute diarrheal disease and some 31,271 cases. A similar pattern is also seen with respect to confirmed cholera and typhoid outbreaks in the country. Coming on to what does this data indicate and what are the gap and challenges? Although the quality and coverage of IDSP data, once we migrated to IHIP, has improved a lot. Earlier, there was aggregate data on a weekly basis, which required a lot of time and effort to be able to pinpoint as to where exactly those cases are being reported from. This now almost in a real time gives us a picture that where exactly the cases and the clustering is happening. But yet there are gaps, especially if we look at the data which is coming from urban areas. That's where the ADD problem actually resides if we try to deep dive. But then the data coming from urban areas is sketchy at best. Maybe it's because tertiary care centers are largely located in urban areas, but our reporting says that most of the tertiary care centers, they do not report satisfactorily on IHIP portal. And also private sector being largely clustered in urban areas, we also see a similar pattern with them. Underreporting, the cases that we saw on the previous slides, both in terms of outbreaks as well as the routine reporting, they reflect only the tip of the iceberg. Well, maybe because only the serious cases or the larger outbreaks, they are captured and reported, but others, the milder ones, and the smaller outbreaks, there's still scope that they may be easily missed. In fact, most of the cases that have been reported, it is would have been serious enough that warrant a second look by a physician or an investigation, and then the reporting part of it. Another major challenge in ADD outbreaks as well as cases is there are, once we look at confirmation of diagnosis, so those were ADD cases, in what proportion of those outbreaks were we able to reach a diagnosis, were we able to pinpoint the etiology. So there are multiple challenges in that, starting from sample collection to transportation of these samples to laboratories, the logistics involved in that, and then the lab itself, whether it is equipped, trained to handle those samples and give a confirmation in a timely manner. By about a few days to maximum a week, the outbreak potential of it, either it would already have become an outbreak, the early warning signal, or by the time we get the result, the results would not be so meaningful to the rapid response team which has been deployed there for that particular outbreak. Availability of point of care or validated rapid diagnostic kits has been a challenge. It's a long-standing challenge. And the availability of such kits, especially the rapid diagnostic kits, would help these RRTs a lot if they are able to come to a conclusion, even if it's a working diagnosis that they can start with. It would be immensely helpful while investigating and responding to outbreaks. So looking at that gaps and challenges profile, there are certain solutions which are being explored by IDSP as well as all stakeholders coming together. So collaboration is the theme, and without collaboration, it is simply not possible given the scale of outbreaks that we have in the country. And most of the outbreaks, I would say, I could go to the data and check it out, but about 50 to 60% of the outbreaks reported through IDSP happen to be acute diarrheal diseases, which include foodborne illnesses. So collaboration, this collaboration is not only with governmental organizations, while we have strong collaboration with ICMR network, the DHD, Animal Husbandry Department, FSSAI, without mentioning FSSAI, we cannot conclude this discussion on foodborne illness and ADD outbreaks. So there are systems which already exist. We are strengthening them so that the data flow across the two systems happens seamlessly. WHO, CDC, and other partners would also figure in this list of collaborators. Strengthening urban surveillance is one major area that is being addressed, especially under the health infrastructure mission that the government had brought in. So metropolitan surveillance units in 20 cities to start with, and then building on that experience would address this problem of gaps in urban areas. Community engagement, making them partners in surveillance, mobile phone applications for physicians, especially in busy tertiary care centers, where if they see the early warning signals or come across a case which might be harbinger of an outbreak, they may immediately report through mobile phone applications. Electronic health records and lab data integration is something which would be very vital in this regard. So already steps are on use of Aadhaar ID, the unique health ID that the government of India has launched for every citizen. So that being used as the single identifier in the system. And lab strengthening are kept separately as one of the solutions. So a public health lab network. I was just going through the comments before as the earlier speakers were delivering their talks. So there was this comment about having a public health lab infrastructure in the country. So under the PM Abhim, the integrated public health laboratories at the district level are being set up, which is integration of all existing labs at district level, merging them into one entity. And then the state public health labs, and at the national level, the NCDC IDSP is creating a national public health lab. So that kind of a network, national, state, and district level public health labs would definitely go a long way in addressing this problem of reaching a conclusive diagnosis in ADD outbreaks. So I'll stop here and once again thank the organizers very much. I'll be available for any questions that might arise. Thank you.
Thank you, Dr. Himanshu, for that comprehensive update of the surveillance systems in India and presenting a picture of how we are recording the foodborne outbreaks and also highlighting gaps and challenges. Thank you very much for your excellent talk. Now we would move on to the last speaker, but last but not the least, Dr. T. Ramamurthy. Dr. Ramamurthy worked in ICMR Nirbi, which was earlier ICMR NICED, in 1997, and he superannuated in 2015. He worked as DBT THSTI National Chair until 2020, and he's working on environmental and food microbiology, and he's currently one of the principal investigators in the ICMR FoodNet project. He has coordinated WHO GNF training programs in India during 2011. He's elected Fellow of Indian National Science Academy, National Academy of Sciences, West Bengal Academy of Science and Technology, and American Academy of Microbiology. He has published more than 300 papers and several book chapters. So welcome, Dr. Ramamurthy, and we look forward to your very, very useful and valuable insights. Over to you.
Thank you, Dr. Nivedita. Good morning, good afternoon, and good evening to all the participants in this program. So, slides are okay?
So we can't see your slides yet.
Now it's okay?
Your slides are not visible, sir.
I did screen share. So.
Dr. Anup, do you have the slides?
No, just I'm sharing.
Yes, ma'am. I'll just load them.
Okay.
Now we can see your slides, sir. You can see your desktop. Yeah, your slides are visible now.
Okay. Sorry
Yes,
for
sir.
the delay. So this talk concentrate more on the key takeaways from the ongoing ICMR foodborne infection project. This is one of the dream projects of ICMR. So thank you very much, Carlton, for showing the nice picture taken way back in 2011 when we hosted the PulseNet Asia Pacific program. So the ICMR project has four major objectives. One is, I'm not going to all the details. The message is identification of any specific pathogen in humans, food, and environmental samples. That we are collecting extensively all the samples per month, on monthly, everyday basis. So the document regional and seasonal variations of diarrheal diseases related to foodborne in waterborne pathogens. And also we are identifying the source of the pathogen that causes outbreak. And finally, when all the identified bacteria goes genotyping and antimicrobial sensitivity pattern. So this is just the probable outcomes of the project. The one arm it is estimation of the pathogens and the detection of pathogens and the AST test, and also centralized data bank as well as bacterial repository. So on the other hand, we have improving the infrastructure development, laboratory diagnosis, as well as manpower training. So in the Northeast India, because this is terrain differences and food habits are so different, and it's also bordered with several foreign countries. So the food habits are naturally different. So in order to test all the existing pathogens in the food, we started this project in the phase 1 as well as phase 2 modes. The phase 2 mode started in 2020, consisting of 4 different states of 5 centers, and the phase 2 that recently started last year. It also has 4 states, and altogether it's 12 institutes involved. So each state covers almost 4 districts, and there's a very vast study area. ICMR is the nodal organization, sponsored this project and also monitors this project. And the National Institute called NIRBI is monitoring the activity as well as, and also the annual proficiency testing we are doing, and also giving training to all the participants. CDAC, this is a digital management training it gives, and also maintains all the data and cleans all the data and reports every month. Finally, the National Institute of Epidemiology, located in Chennai, is coordinating all the outbreak investigations and giving training for the outbreak investigations. I'm not going to the details. So this is different samples collected from market that includes state-specific food, hospital surveillance, animal surveillance that is included in the phase 2 project, wherein all the feces of animal origin, including animal handlers, related with all the animal samples collected. And outbreak investigation, whenever the outbreak investigation with the collaboration with the IDSP, we are doing all the outbreak investigations. And this specific number of samples collected per month is also shown in the slide. And the laboratory investigation conducted to identify the particular pathogen using different conventional and PCR methods. And once the confirmed bacterial isolates will be being sent for confirmation to NIRBI as well as to the laboratory. This is a very busy slide, but the message is the collected samples different from different sources by different field workers are now entered into the system in a proper way, which has a web application as well as a mobile app and geomapping, and then the data entry, laboratory processing, and partially some of the specimens goes for metagenomic analysis to identify the unknown or unculturable bacteria or any entry pathogen. And we have a specific website where one can log in and do the enter all the data. But at the moment, we don't have public access to all the data, whatever we are generating. It will be released soon, maybe after completion of the phase 1 project. In the resource part, we have all the information regarding publications or the standard operating procedures, what we developed for this particular study. This is open to all. So we have more than 20 targeted pathogens in this project. The phase 2 project in the last, you can see in the left-hand side, Leptospira, Mycobacterium bovis, Brucella. These are all closely associated with animal or pathogens of animal origin. And we are detecting, because of the delay in the incubation, Leptospira and health hazards related to Mycobacterium and Brucella, we are detecting by molecular technique after preserving the sample from the site itself. So this is the combination of conventional and as well as molecular-based detection. Fungi, yes, we are detecting the toxigenic parts. Just I'm giving highlighting some of the recent results. You can see the top 5 pathogens what we identified is diarrhegenic E. coli, consisting of pathogenic, hemorrhagic, or enteroaggregative E. coli. That the percentage varies from the source, hospital or phase 1, phase 2 study sites, as well as the animal surveillance. We identified Listeria monocytogenes. So these are all just a number of confirmed bacterial species we had in our repository. So notable observation, we identified 3 new serovars, first time reported in this country, Uganda, Takoroti, and Tenevir. And all these non-typhoidal salmonella has invasive gene, means it has a potential to cause the disease. Shigella dysentery type 1 once it was assumed as an extinct or dead organism in the epidemiology of dysentery. We could identify one Shigella dysentery type 1 from Sikkim. And way back in 2016, we published in collaboration with the Pasteur Institute the whole genome sequence of Shigella dysentery type 1 collected from 1951 to 2011. So it has about more than 500 strains. So we could identify based on the SNP, the 4 different lineages. And if you consider the beast analysis, it always has the origin of several types of Shigella dysentery in the Indian subcontinent. The recently identified Shigella dysentery type 1 from Sikkim from the food sample belongs to lineage 4. Multi-drug resistance is very common in Shigella dysentery. In the first half, you can see oddly the resistance was very less, and towards the bottom, you can see the resistant gene prevalence as well as the phenotypic resistance is very high in Shigella dysentery type 1. And the recently identified Shigella dysentery type 1 is also multi-drug resistance. And all this multi-drug resistance we could identify in the Shigella resistance gene locale, pathogenicity island. Salmonella typhi, it causes septicemia or bacteremia, but it's also associated closely with several food contamination, especially through animal handlers. So we identified several Salmonella typhi from several food samples from all the almost 3 or 4 states of Northeast India. You can all the types we identified belongs to 431 sequence type. And there are certain variations because of some mutations, but all belongs to the same 431. The less appreciated organism, Proteus mirabilis and Bacillus cereus. Bacillus cereus is more assumed to be or said to be associated with released toxin that is readily available in the food. Whereas mirabilis is just like another form of enteric bacteria. So when we tested through the whole genome sequence, we could identify all of the potential for causing urinary tract infection. And we also did the analysis whether any of these virulent genes associated with the diarrhea. Yes, we haven't done any animal model study yet. And type 3 secretion system or stress adaptation, adherence, enterotoxin invasion, these are all closely associated with diarrheal infection. And AMR, it varies from strain to strain. Some are highly resistant, some are resistant to only chlorophenicol. Sorry for the busy slide. This is a Bacillus cereus. As I mentioned, the toxin. One is the emetic toxin, the other is a diarrheagenic toxin associated with the hemolysin or non-hemolysin. So some of the strains in red rows shows it has potential to cause the emetic as well as diarrheal infection. So this is all our list of publications that is available to all. These are all open access publication. And I would like to thank Dr. Madhu Chandradas coordinating this project from my CMR and my colleague Ashish Magapadhyay, OPI of this project, Samrit Das, who is controlling all the management challenges in CTAC, and Dr. Santosh Kumar, who is helping us for all the investigations related with outbreaks. I would like to thank all the PIs in this project for their hard work. And we have a monthly meeting for the data presentation and see the progress always. So with this, I would like to conclude and thank you for the opportunity again, Dr. Nivedita, and to the ICMR team and to my colleagues. Thank you.
Thank you very much, Dr. Ramamurthy, for that comprehensive overview of the ICMR FoodNet project and showing us a lot of good work that has been done under this project. Thank you very much for sharing those insights. Yeah. So I think you can stop sharing your screen, Dr. Ramamurthy.
Yes. Okay.
Yeah, you have to stop sharing. Yes, thank you very much. And that brings us to the end of all the excellent talks that we heard today. And fortunately, Dr. Carlton, and thank you to you, you have answered almost all the questions that were put in the chat box. But there are quite a few that we received offline and they are still there in the chat box. So I will read them out. So the first question that I see is unanswered is from Dr. Naveen Kumar, Director NIV. He says that in India, most of the food poisoning cases are underreported and are not being investigated. What measures to be taken to prevent and reduce food poisoning outbreaks, and how reporting can be improved to eradicate implicated foods? So, Dr. Himanshu, I would request you to kindly answer this question.
Yeah, thanks. So let me just quickly refer to that question once again.
It's in the chat box towards the end by Dr. Naveen Kumar.
Right. Just trying to locate it. Sorry about that.
Should I read it again?
In India, most of the food poisoning cases are, yeah, got it, are underreported and are not being investigated. What measures to be taken to prevent and reduce food poisoning? So this is, the issue has been very rightly identified. And since you are also, sir, a part of that system that sees it almost on a daily basis and tries to find a solution to it. So it starts with a joint outbreak investigation. What is the issue in this is that in our ADD outbreaks, because we do not have a separate drop down or a separate entity which says that these are foodborne illness outbreaks. Because for that, a working starting hypothesis can be that it's a foodborne, but then you'll have to conclude it by picking up food samples and investigating them. So the food samples get investigated on a different line, while the human samples have a different channel of investigation follow-up. So the IDSP guidelines right from the beginning says that the food safety officers at the district level and at the state level, they need to be a part of the RRT that is deployed for investigating that. And while things are improving and there are states which have taken a lead in this direction, but still there is a lot of scope. The involvement of both the sectors working together, there's a lot to be done in that area. While for the alerts, I would say that most of the alerts, they are picked up and they are sent to the health authorities who then respond to them in time by verifying that and starting the investigation. However, the investigation it doesn't reach a logical conclusion in the absence of samples being collected from both sectors. So that's my take on this, sir.
Thank you, Dr. Himanshu. And there's another question. I would request any laboratory expert who's there in the group or any of our speakers. Can you comment on a lot of clinicians and private labs diagnosing typhoid based on Vidal test? No cultures are ever obtained. Would any of the experts like to answer that?
Yeah, Vidal test, yes. Traditionally, we are doing. So, in India is one of the countries still practicing Vidal test, but it is based on the titer. The clinical infection is based on the titer. One have to be very, very careful in reporting. This is more than 4 times dilution positive. Yes, we can assume this is a typhoid related infection. Otherwise, conventional culture method is still being followed in all the clinical laboratories. That takes time, but yes. But in developed countries, no one is doing a Vidal test.
Yes, and to add on to what Dr. Ramamurthy said, that when you talk about private labs, small labs, and they are highly relying on Vidal and not doing culture, we also have to remember that doing culture is cumbersome. It is not easy to establish cultures everywhere. There are a lot of issues related to contamination. And if you don't have dedicated areas to run cultures and maintain them, then their contamination becomes a huge problem. Sensitivity of cultures is very low. So now the entire world is looking for faster solutions, looking at possibly developing molecular methods for detecting typhoid in the acute stages and reduce the reliance on cultures. Okay, then I would move to the next question. I don't think there's anything much left here. I would move to some other questions and request our colleagues from CDC if they have any insights on this. How can technology and artificial intelligence improve foodborne disease surveillance and early warning systems? So, any comments on that? Dr. Carmen or Dr. Carlton, anything on that part?
Sure, I could come in perhaps and then be complemented by our colleagues from CDC. I think like a lot of you probably were really excited to see all the developments with artificial intelligence. It's one of the areas that has not been addressed in our suite of manuals, but WHO separately has been producing guidance on how artificial intelligence might be able to be applied to areas like surveillance. And so we're hoping actually to include some guidance and case studies from countries which have piloted this technology in order to, for example, help with hypothesis generation during outbreak investigations, and perhaps complement or at the outset of investigations, help speed along data analysis, which then would be complemented by epidemiologists. So I think as it's rapidly evolving, we're also following carefully and looking to see what kind of guidance we can provide to different countries to harness that, particularly when resources might be limited.
Yeah, and I think there's another question in the chat box to Dr. Ramamurthy. Are we doing routine viral agent testing for gastroenteritis under the ICMR project?
Yes, I have listed about 5 or 6 in very common enteric viruses. Yes, we do by reverse transcriptase PCR. Using, especially in the stool sample we are doing, but in food samples, the detection rate is so low because we haven't identified any viral pathogen from the food so far.
Okay, and I would like to take the last question now. Somebody has asked, what are the natural ways of keeping the food disease free? So I think, would anybody like to take it?
Maybe can I say something on that?
Yes, sir. Yes,
Yeah,
sir.
he is the correct person. Yes, Dr. Iday.
Thank you. Yeah, one thing I think what I would like to say is nowhere we can say it is disease free. It's almost impossible. But we can only try to reduce the hazards associated with the food. And what I would like to say is, of course, the Codex guidelines would help the industry, the food industry, because it gives guidelines right from primary production till it reaches the consumer, what needs to be done at every stage to minimize these risks. And these are based on scientific risk assessments. So I would suggest looking at the Codex guidelines and codes of practices in each sector. Thank you very much.
Thank you, Dr. Karuna Sagar, for taking that question. I think we come to the end of the question answer session, and I would now hand it over to Dr. Anup Velayudhan, Senior Scientist from ICMR, to give the vote of thanks. Over to you, Dr. Anup.
Thank you, madam. So I would like to especially thank at first our speakers for providing such a wonderful session. It was quite very well presented, and the information that you have presented in your slides are very, very important, and it gives a very intense insight into what is happening, and which is very novel, with which we can look at in the whole gamut of foodborne infections. I would especially like to thank Dr. Sevelli, who has joined us from WHO, and Dr. Carlton, who has actually joined us in the early hours of morning from Georgia, Atlanta. And my special thanks to Dr. Karuna Sagar, Dr. Himanshu Chauhan, and Dr. Ramamurthy for enriching us with their experience and also telling us about what is happening in India and in the novel projects that are coming up in India. So also I would like to thank the CDC India team, Dr. Mayank, Dr. Runa, and Dr. Ravinder for helping us with organize this webinar along with ICMR. This is a co-opted webinar series by the ICMR CDC India team, and we hope to keep this momentum going by introducing more topics from One Health in the coming webinars. Thank you all for joining us today, and so many thanks for your questions and queries also. Thank you.
Thank you. Thank you so much.
Thank you. Thank you all for joining. Thank you.
Thank you.